Very good, everybody. Thank you for coming. I think we'll go ahead and get started in the interest of time. Bienvenue. Welcome to the second Innovation Challenge, a Canadian Virtual Hospice initiative and original innovation from Canadian Virtual Hospice Executive Director Shelley Cory. Je m'appelle Cory Ingram, and I'm proud to be your MC today. And when I'm not in this spotlight, I'm privileged to work shoulder to shoulder with hospice and palliative care interdisciplinary team members like all of you. Truth be told, there's nothing I would rather be and nothing I would rather do than be a part of a team to provide patients and families the best care possible through the end of life. Perhaps one of the best innovations in our field was the creation of our hospice and palliative care interdisciplinary model of caring with deep roots right here in Montreal. So thank you all for what you do. Thank you for your presence at this Congress. And thank you for coming today to learn which of our 6 finalists will become the 2022 International Innovator of the Year. I want to introduce you to our panel of judges, sharks, or dragons, however you want to see them. First, we have Dr. Roz Taylor from the United Kingdom. She has been a practicing palliative care physician for more than 30 years and is currently the medical director of Harlington Hospice and Michael Sobel Hospice in England. Next, Dr. Kathy Kortes-Miller from Canada. She's associate professor in the School of Social Work and director of the Center for Education on Research and Aging and Health at Lakehead University in Thunder Bay, Ontario. Yeah. There you go. And to my left, Dr. Ricky Leiter from the United States, palliative care physician at the Dana-Farber Cancer Institute and Brigham and Women's Hospital and instructor of medicine at the Harvard Medical School. So in the next 78 minutes, we are celebrating innovations in palliative care. And we've received many submissions from many countries, and all the submissions were reviewed and scored by a team of 4 international reviewers to narrow it down to the 6 you're going to hear from today. Our reviewers are 2018 Innovation Challenge winner, Holly Prince. Woo! Dr. Alan Batt from Australia, Dr. Kim Widger from Canada, and myself from the United States. Each presenter today will have exactly 6 minutes, no more than 6 minutes, to present their innovation, and I'm keeping track of the time. After that, the judges will have time for questions and commentary, similar to Sharks and Dragons you may have experienced on popular television shows. You will have an opportunity to vote for your favorite innovation after you've seen all 6. And there'll be instructions on how to do that on your mobile devices. Winners will be determined by the judges with input from the voting audiences, and we are also streaming this presentation live via Facebook live stream on the Canadian Virtual Hospice Facebook page to allow Facebook users around the world to vote as well. And while the judges deliberate, we will announce the winner of the mini iPad from the Canadian Virtual Hospice drawing. And then, before the clock strikes 2 and I make a mad dash for my flight, a winner will be named International Palliative Care Innovator of the Year for 2022, and, very generous, will receive a $1,000 prize from the Canadian Virtual Hospice. So, with that being said, let's get started. Our first presenter today is Dr. Conrad Fassbender, Covenant Health Palliative Care Institute, presenting Compassionate Alberta.
Thank you, and cue the video. My name is Conrad Fassbender. I'm the Scientific Director of Covenant Health Palliative Institute. On behalf of the Institute, I'd like to thank Canadian Virtual Hospice reviewers and judges for this opportunity. I'd also like to acknowledge the contributions made by the other finalists and say that we are humbled to be in your company. Compassionate Alberta partners with community organizations to promote public health and literacy, strengthen healthcare, and quality of life for everyone. A website, toolkit, and app provide resources and strategies for organizations and individuals to understand palliative care and advanced care planning in a supportive environment. Imagine living in a community where everyone is ready and willing to support each other through conversations about living and dying well. So I'd like to introduce the life planning approach. We know that palliative care and advanced care planning are not solely the domain of the healthcare system. A holistic approach takes advantage of the fact that financial and estate assets are often considered at the same time as planning for future care. According to a 2021 Nanos public poll, 40% of respondents agree that advanced care planning should be done earlier in life. Precision communication takes advantage of both the opportunity and incentive to learn. Significant life events such as school, getting your driver's license, getting married, buying property, landing a job, getting sick, or retiring facilitate targeted messaging at the right place at the right time. Dr. Alan Kelleher explains why personal experiences are so powerful and how this innovation helps to set the stage to support one another.
The success of the public health movement in palliative care, or the compassionate communities movement in palliative care, is the sheer number of people in business and in church and temple and mosque and in schools who've been personally affected by death, dying, loss and caregiving. Surprising numbers of people. And when you approach them and when you put them in the same room, enthusiasm just burns. They get involved, but they need to be shown. They need to understand where they fit into the bigger fabric of things.
Dr. Kelleher also reminds us that this type of innovation is not only effective, but cost-effective and a prudent investment.
When I first started in this business 25 years ago, some clinical palliative care people were wondering why the state governments in Australia, which is where I started this, why the Australian government were pouring resources into public health innovations when we needed more beds, when we needed more training for palliative care registrars, more training for palliative care nurses, and it's a limited pot. But actually, what happens in public health, world, and we've got lots of evaluations to prove this in drug and alcohol and maternal health site care. For every dollar you spend in public health, you save about 3 in clinical services.
The building blocks or foundation for Compassionate Alberta starts with the idea that healthcare is everyone's responsibility, as eloquently stated by Dr. Alan Kelleher in his 2013 seminal article.
No one ever believes that death will come to them, but it will, and it does. And that's why compassionate communities are also important, because we will need them. Those we love will need them. And doctors and nurses and professional health services are not enough. They're not enough. They've never been enough.
Together Stronger summarizes the key learnings from Palliative Care Matters over the last 6 years and marked the beginning of this innovative journey. Public polling and consultation confirmed the need to raise public awareness and ultimately resulted in a Conference Board of Canada action planning and other reports. If you want to fix the healthcare system, ask the patient, ask the family, ask the public. The enthusiastic participation and voices are exemplified by Serena
Coming here
Nanya.
to this conference, this exceeded my expectation because we got to talk about systemic issues in our framework.
It was a lovely feeling for me of all being on the same page. So I certainly hope that not only filters through this day, but that as these things I think actually do work, that's part of this fractal that our influence in the world just goes outward in this pattern that we don't really have any control over.
This website and accompanying resources are the result of extensive co-design, identifying, understanding, and engaging community organizations who are passionate about supporting Albertans to learn about their health, their healthcare options, and opportunities to get their affairs in order. We are grateful to the palliative and hospice societies, libraries, faith-based organizations, legal communities, financial planning communities, and public at large. You are not alone. Imagine living in a community where everyone is ready, willing, and confident to support each other through conversations about living and dying well. Thank you.
That's wonderful. Thank you, Dr. Fassbender. I'm wanting to turn the mic over here to Dr. Leiter for commentary and questions.
Yeah, thanks so much. So just quickly, I told my wife I was doing this, that I wanted to be Mark Cuban from Shark Tank, and she said, because I'm in Canada, I have to be Mr. Wonderful. So no. But
Mr. Wonderfuls will ask you a question now.
No. So wonderful presentation, wonderful program. I'm wondering, how do these programs oftentimes reach the people who are most willing to hear the message and most open to it? How do you reach the people who aren't, who are scared, who are reluctant, the most reluctant to talk about death and dying?
Yeah, so precision communication means that there's a targeted strategy for each community. So faith-based organizations, for example, Catholic, Muslim, other communities, often in traditional public health rely on going to a website without help. But if you train the trainer, if you train representatives from the communities, from the churches and schools and other communities, they are the translators. They're the ones who can motivate.
That's great. Thank you.
You're welcome.
Great work.
Thanks.
Any of our other sharks have a question, comment? We have another minute and 30 seconds.
All right, then I do.
Okay, we got another one.
Conrad, tell me, how are your communities asking for this? Because that's really the message with compassionate communities. It comes from the communities.
Well, each of the communities has a constituency. And so, as Alan said, they are burning for, and they're looking for resources to share. They need that help.
I hear that, and I'm fully versed in Alan's work. But how are your communities asking?
So what do you mean by my communities?
Your communities. I recognize we're supposed to be not so nice, just to be really clear. That was our direction.
And you only have 55 seconds,
Okay,
just be really clear.
I recognize everybody in your videos, Conrad. I don't live in Alberta anymore. How are you getting out there and hearing from people who aren't representative of the palliative care community?
Well, we've engaged financial planners and legal folks, and so they're not part of our community. One of the exciting things is once you go outside of healthcare, we have 9 ministries that have signed on. The public release was signed by 3 ministries, and so getting municipal affairs, getting the lawyers and the financial planners, the estate planners, the bankers, they recognize that personal directives and enduring power of attorney are things you do at the same time. So we've been successful.
Thank you.
Thank you.
Aww.
Very good. How about a nice round of applause?
Thank you. Thanks so much.
That brings us to our next presentation, and I am very pleased to welcome to the stage Dr. Ruth Lagman from the Cleveland Clinic on implementing individualized care plans in high-risk oncology patients, a team-based model to increase hospice utilization.
Cue my slide, please. Good afternoon. My name is Ruth. I've been caring for individuals and families with serious life-limiting illnesses for over 25 years. I probably cannot say that I've seen it all, but I've lived through many challenging experiences on how to care for these individuals. I must say that I've been both humbled and grateful for every opportunity to help each one of them. I would like to share with all of you our story, as it provided us an opportunity to look for a different way to care for cancer patients undergoing the most difficult of circumstances. This is a wonderful time to be alive. The scientific advances that have come about in the past 50 years have enabled individuals to live longer. Cancer survival rates have increased from 49% in the 1970s to over 70% in 2017. About 3.5 million cancer deaths were avoided since 1991. Imagine that, 3.5 million. These are due in part from the therapeutic advances in the treatment of cancer, particularly targeted therapy. Moreover, many of us are doing our part to be healthy, not smoking, avoiding alcohol, better choices with food, exercising, and prioritizing sleep and self-care. Efforts to prevent getting sick in the first place. Yet, 600,000 individuals will still be diagnosed with cancer every year in the United States. Cancer is still a serious disease, as patients experience complications either from the disease itself or the treatments they are receiving. When they get sick, they do so very quickly. We notice that there can be individuals that would have frequent admissions, likely several times in a span of 30 days. We call them frequent flyers. So what did we do? We formed a committee that met every month to understand the needs of palliative of these patients and families, and why the frequent readmissions in the first place. Oncology, palliative medicine providers, nurses and social workers formed the core of the team. The goal was to come up with an individualized care plan to assist providers on how to better serve the patients and families. However, during the course of the work done by the committee, all the while we were intently focused on reducing readmissions, we happened to notice about something really significant. There were individuals that were just too ill and too frail to continue their cancer treatment. Either the burden of their disease and/or the adverse effects from the cancer treatment, however individualized, were just too difficult and challenging for the patients and their caregivers. Hospice as an option was then brought up as part of their treatment plan of care. This was probably the more appropriate care at the time of their disease trajectory. In 2 years, we looked at 39 patients who had passed. 87% enrolled with hospice care. 2/3 did so within 60 days upon the ICT recommendations. 3/4 stayed in hospice more than 30 days, and the median length of stay was about 26 days. This is significant and quite important, as early enrollment in hospice care have increased survival time, ironically, decreased hospital utilization, decreased aggressive end-of-life care and treatment, and most importantly, patients and families reap the benefits of hospice care. Cancer treatments will evolve and will likely touch and benefit millions of patients and their families. It is estimated that 2.3 million individuals will be diagnosed with cancer by 2040, just because of the aging population. It is very likely that most will benefit from newer and better cancer treatments that will be coming out in the future. However, there will still be some individuals that may not be helped by these new innovations in cancer care. The work continues for this interdisciplinary care team. While several members have rotated out of the committee, the core structure, its operations and original goals and now early identification of patients eligible for hospice care continue on. Talk about sustainability. We are honored and grateful to the organizers for giving us the opportunity to present our work. Thank you.
And thank you, Dr. Lagman. I'm going to turn it over to Dr. Ross Taylor for first commentary and questions.
Okay, thank you. Ruth, I'm from London, and I've worked in a cancer hospital, not quite as prestigious as the Cleveland Clinic. And in England, we call it Dragon's Den, not Shark's Tank. So, first mean question. What was happening before your committee?
What was happening? It was not, how would I say it? It was just palliative care, doing most of the work, transitioning patients to hospice. Very sick individuals were being transitioned to hospice just with palliative care. So what had happened was the metric, the new metric was to reduce hospital readmissions. And that was when that was when oncology really got involved, because of course now it's affecting reimbursement and metrics. So that was when officially there was a committee found. And I get your question. I've been in the Cleveland Clinic for over 20 years, and you are correct. And I've been a palliative care physician with the Cleveland Clinics, and I do get your question. Yes.
Okay. One last key question: how did you persuade oncologists?
Well,
if you want to think about that.
No, actually, I see the oncologists as partners, and they see us now as partners. Palliative care has been very integrated in the Cleveland Clinic since I started. I have seen the transformation from very aggressive treatment at the end of life to being partners at the beginning of the cancer diagnosis. That has changed, really changed.
Okay, congratulations.
Thank you.
Yeah, can I?
Sure.
Yeah, Mr. Wonderful. Dr. Wonderful, right?
Thank you.
Yes.
How does this work outside of somewhere like the Cleveland Clinic? I mean, we're both at these, institutions, and I think it's reasonable for people to say, well, you're in the ivory tower, this doesn't work anywhere else.
I think that's partly correct, given that I face it, palliative care is interdisciplinary care. You can't do it alone. You need resources. Yes, that is partly correct. But I don't think that limits of resources should stop us taking care of patients. Yes, I get it.
Great. And Kathy, we do have a minute or two.
Sure. I'm interested, where does the chosen family fit in with the individualized team planning? How do you...
Excuse me, what is it?
The chosen family. How are you including the family and the community into your planning?
Oh, yes. The social workers are actually involved. Believe it or not, we have never cracked we haven't found the holy grail to reduce readmissions, but we found out that every family, if the social worker is involved, we're able to reduce that. So I just wanted to let you know, we involve either the social worker in the outpatient, the inpatient, or even in wherever they live, or the nursing home.
Thank you for plugging my profession.
Yeah, I was going to say, a round of applause for social work, and then I have a question.
Yes.
I'm just wondering, how did your hospice respond to this?
Oh, they were very pleased, of course. Clearly, any time that you get an early admission to hospice care, everybody benefits. I can say clinical outcomes, patient and family satisfaction, of course, and of course we don't do this, but in the United States, Cory, financial outcomes are always an issue. So, but I think it's a win-win situation for everybody.
Yes, I agree. And I wasn't joking about that round of applause for social workers, so if we could just have for social workers right now. And then for Dr. Ruth Lagman, thank you, Ruth.
You're welcome.
And for Dr. Lagman, yes, very good. This brings us to our next presenter. I want to introduce Bev Foster, presenting, Bev Foster, room 217, presenting culturally diverse music creation as a prototype for effective intercultural collaboration in healthcare.
In Canada, a country where the population is increasingly ethnically diverse, with a rich tapestry of traditions, cultural practices, and worldviews, how do caregivers meet the needs of families at end of life? Music may be a solution, because music has the universal capacity to speak directly to our hearts and souls. I can bear witness to that from my own personal experience. When my dad was dying, my family surrounded him and sang his songs. The songs that had held meaning for him in life helped him in death. And they helped us too, by bringing us comfort and a means to express our gratitude and goodbyes. That experience changed me. As a musician and family caregiver, I wanted other families to have tools and resources available so they could support their loved ones with music. So with the help of caregivers, palliative care professionals, and musicians, we created a design. Now more than 50,000 units of our first 12 albums and thousands of streams and digital downloads have been delivered across Canada into private homes, hospices, hospitals, and long-term care homes. And users have told us some of the benefits of our design music. It reduces agitation for all in the circle of care. It assists in tasks of relationship completion. It decreases feelings of fear and isolation, helps with pain distraction, and provides comfort and opportunity for connection. Users told us something else too. They wanted more, but targeted to two specific groups, baby boomers and newcomers to Canada. Our team understood the cultural meaning and musical constructs of baby boomer music, but newcomers to Canada, we knew our cultural competency was limited, and we would have to get expertise from others. We had lots of questions. Would our current design work interculturally? Which musics would we use? How would we go about getting master musicians from those cultures? And what are the soothing sounds in these musics? And is music even used in death and dying rituals? The innovation I want to share with you is what came between the creative idea and the tangible collection. At one level, the process isn't innovative at all. It's the process to make any album: pre-production, production, post-production. What is innovative, though, is how we shaped the creative process for an effective intercultural collaboration. We reframed it to listen, co-create, and share. Before we did anything, we hired co-producers to facilitate the process. These award-winning musicians have backgrounds in world music, music therapy, ethnomusicology, and music production. The dream team. Aaron and Justin have an extensive network of ethnically diverse master musicians living in Canada. Now, they recommended we focus on 6 geographically representative albums: South Asia, the Mideast, South America, Africa, East Asia, and Indigenous North America. They also recommended we use iconic sounds rather than songs as our content. So step 1 was all about listening. We did a survey, got advice from national hospice leaders, and we held focus groups, one for each album, consulting with diverse master musicians, seeking to understand death and dying rituals and what soothing sounds meant in their cultures. Then musical sketches of each album were created. Step 2 was all about co-creating. Now, most of the albums required at least 10 studio sessions, and musicians were encouraged to improvise using the most calming and soothing aspect of their musical languages. Watch Wendy Seow, a master musician, playing the pipa, a traditional Chinese instrument from the Bamboo Garden album. And here's Lasso Sanu, a master musician from the playing the West African rhythm harp, the ngoni, from the Heartbeat album. Step 3 was all about sharing. The music and artwork were refined further by group input but from the musicians so that the artistic and cultural elements were balanced. Personally, I had 3 key learnings from engaging in this project. Cultural competency, humility, and collaboration aren't just words. They need to be embodied in a very real and actionable way in the process, with a commitment to cultural safety for us all. Intercultural collaboration is a rich, shared human experience. Musicians told us it was one of the most meaningful projects they had been part of, and our team learned so much from the more than 25 musicians involved. And we know that our music now reaches more Canadians. The process takes more time, more expense, more planning, but it's worth it. The rewards of creating something together that is deeply respectful and authentic is something we are all proud of. We go somewhere together. We cannot go on our own. For us, our Listen, Co-Create, Share process has been a pathway towards serving more Canadians in life-limiting circumstances. It's a pathway of connection and honor. And in this spirit, I suggest this creative process could be a prototype for other intercultural endeavors in Canada and around the world. Thank you.
And thank you, Beth. So I'm going to turn it over to Dr. Kathy Kortes-Miller. If she asks you a really mean question, I may have to cut her mic.
I think Roz is
Oh.
beating me to it.
Oh,
Okay.
I'll follow up.
okay, you'll follow up. Okay, good.
That was an amazing presentation, Bev. I've heard your work before, and I love the process that you use to become so collaborative. My main question is, how do you measure the reduction in agitation?
Oh, you're going back to that. Okay. Yeah, so we did a study in 2013 and 14. So this was pre this innovation. I'm just talking about our music in general, right? And so it was a qualitative study. And we've done a pilot with McMaster University to test that very thing. We've just done a pilot. It's just being presented now in the research literature.
Yeah. Okay, thank you very much. And my second question is, do you have to be ill to access your wonderful resources?
Oh, that's the great thing, right? You don't have to be at all. And it's available. You can access the music on Spotify. You can download it. And you can.
Yeah, I'm just thinking of our very culturally diverse caregivers, informal and professional.
Well, that's just it too. Yeah. And I think, I'll tell you this. I only shared 3 things I've learned, but I'll tell you maybe one of the basic things I learned even before this process from Erin is that there's a bit of a myth that just because you're from England, you're going to like certain music because it's part of your culture.
I like that.
Exactly.
Yeah.
And that's perhaps it was a myth buster for me. And opened me even to like entering into this process, right? It was just sort of a baseline learning. So don't even make those, well, you've got to make some assumptions, I think, when you're caregiving, a few, but be open because you might be surprised.
Yes. What a good point. Kathy?
Mean or nice?
I'm not sure yet.
Okay.
But again, I echo Roz and want to thank you for your presentation. And like Roz, I'm quite familiar with the work that you do. And so I'm really interested, Bev, why this innovation right now? Why did you go in this direction for this period of time?
Because the people we serve in hospice palliative care asked us to. Right? When we did that 2013 and 14 study, they asked us, could you please give us music for boomers and for newcomers because they're populating our hospices. And I was like, I'm going, how do I do this? I mean, I'm a white settler. Like, how do I do this? So you get help.
Can I ask one?
Yes.
Okay.
Quick.
So, I'm born in Canada, and my whole team knows that if I'm ever, in the hospital sick, I want to listen to the Tragically Hip, Great Big Sea. Okay, I'm totally stereotypical. But so, what makes your program different than us just finding out what music the people like and playing it for them?
Yeah, it's designed. So we design it at 60 beats per minute to entrain with resting heart rate. And what was really interesting in this innovation, that got so tested, and generally speaking, it stayed in that zone. But for example, in the African stuff, the distinctive about their cultural music, it has the inner beats and the inner rhythms, which make it almost sound faster, but it's not. That's just one example. We use a textured approach, like very thin texture. I could go on about that, but it's design music.
Thanks.
Okay?
How about a round of applause for Beth Buckle? Very nice. Very nice. And now I have the pleasure of introducing Dr. Hsien Seow and Dr. Samantha Winemaker from McMaster University presenting 7 Keys to Empower Patients, Families, Deconstructing a Palliative Care Approach for the Public. Thank you.
Hi, I'm Hsien Seow.
And I'm Sammy Winemaker. We talk to people who have information and tips on how to unlock a better illness experience.
The waiting room revolution starts right now. Hi, welcome to a special live recording of the Waiting Room Revolution. We are in Montreal at the McGill International Palliative Care Congress. Hello to our special guests, this amazing audience, and Canadian Virtual Hospice for hosting this event. Today, we are featuring a special 5-minute podcast episode where we are answering questions from social media and the audience. So let's jump right in. Our first question comes to us from Twitter. It asks, can you tell us more about this innovation, the 7 Keys to a Better Illness Experience? What is that?
We thought about the thousands of patients we have served and listened to, and we compared those who felt utterly overwhelmed and those who felt more prepared. What was different? We reverse engineered what they told us a good illness experience would be. We deconstructed the elements of an early palliative approach. We broke them down into simple metaphors that were actionable, that patients and families could do early in their illness. This was essentially teaching them how to leach out a palliative care approach without the labels. We ended up with 7 keys. These are the 7 keys for navigating a life-changing diagnosis. For instance, one key is called Walk 2 Roads. Walk 2 roads, meaning to learn how to hope for the best and plan for the rest. Or another key is zoom out, which is to step back and look at the big picture of the illness and understand where they're at in the overarching storyline. These are 2 of 7 keys. Our keys unlock a better illness experience so patients and families can take charge of their journey. These 7 keys are our innovation.
All right. Okay, let's go to our next question. It comes to us from TikTok.
Hi, Dr. Sammy. I love your videos. They've helped me so much with understanding what my grandma's going through with her illness. I'm creeping your account, and I noticed at Waiting Room Rev. What is that all about, and why did you start that?
Okay, maybe I'll take this one. So Sammy and I discovered the 7 Keys, which is our innovation, and it's innovative because it targets patients and families. It's meant for them to use and own. These actions are how we hope they'll be able to improve the entire journey, not just the end. So what is the waiting room revolution? We had to package those 7 keys into a social movement to help spread them. A social movement is a group of people coming together for a common purpose, like Me Too, or Black Lives Matter, or March for Our Lives. Our movement is about bringing patients and families and communities together to be more activated, empowered, and knowledgeable and informed. That's the movement. And we named it the Waiting Room Revolution because patients and families are waiting in metaphorical and literal waiting rooms every day, scared, confused, worried about what to expect. We wanted to have a revolution and make that a place where they're in control, empowered, and can take charge. So the Waiting Revolution is the vehicle to spread the innovation. Okay, our next question comes to us from Instagram. RoboServe says, this info is so helpful, it should be everywhere. How are you spreading the word?
Good question. Once we discovered the 7 keys, we thought, now what? We wanted to get this information out there fast. We have a website and a weekly newsletter. We're on all social media platforms, even TikTok. And of course, we created this podcast, which is in the top 2% of global podcasts. It's in its 5th season. We have listeners from all around the world. We've been busy building a larger change community, a true social movement. We have a wide range of guests, including rock stars from the palliative care world like Catherine Mannix and Naheed Dasani. And just released this week, a real bona fide rock star, Biff Naked. That's how we're spreading the revolution.
Okay, now we have a random question from the audience. Oh, I see this lady in the pink. What's your question?
What are you the most proud of?
Oh, great question. Thank you, lady in the pink. Well, we are proud that we tried to offer a solution to a very complex problem. We looked at that problem from the patient and family perspective, which resulted in the 7 keys, our innovation, and it's a deconstructed and accessible version of a palliative approach to care without the labels. And this is relevant not just to where all our listeners are around the world, but in every waiting room, everywhere. And we co-designed this with real people. Oh, just kidding. So that the 7 keys are simple and everyone can be a part of it. So if you are a provider, we hope that you can use these keys so you can invite patients into the conversations earlier and give them a palliative care approach without the labels. And if you are a patient and family, you can use the keys to get a better illness experience throughout the entire journey. That's all the time we have today. Thank you to our live audience, to which we say, welcome to the revolution.
Very, very nice. Which of our sharks is going to want to take first shot here?
I think I've got that one.
All righty.
Thank you for hosting us on your podcast. I listen to a ton of podcasts, and every time I listen to a great podcast, I'm like, this is going to change my life. And then I go to work or I get home and I totally forget about it. So how do you make it stick?
The podcast is just the beginning of a social movement. It got us attention and got us on the stage, but in every podcast, every guest, we are asking for actionable tips, telling their stories, trying to change hearts and minds, but it's not just a podcast. It's information on TikTok. It belongs to the people, and we want to use this as a catalyst for forming communities where they can talk about these issues and and share what they don't know they didn't know. So we see a book coming out. We see Facebook groups that they already form, infiltrating that. We want to create tools that are geared to the public in language and metaphors that they can pick up right at the diagnosis, not at the end where at what point do they get a palliative care referral.
Very good. We have time for one more question.
I was just going to ask, Google Analytics, who are your listeners? Who's listening to the podcast?
That map was true. We have listeners from all over the world. It's not a surprise that we started a lot of them are from Canada. Beyond the analytics, we don't know a lot about the age groups, but on social media and stuff, I think it's a wide range of patients and families. Wouldn't you say, Sammy? I mean, some of them are young baby boomers, the sandwich generations who are caring for their parents. A lot of them are older caregivers who have already gone through the process and said, I wish I had done this sooner. This explains so much. It relieves this sense of burden that they didn't do it right, or having this information now says, I understand what I just went through, and now I can start the healing process. So I think that's a wide range, and as you know, palliative care is everyone's business, and illness and health and a life-changing diagnosis affects us all.
Very good. Well, how about a nice warm round of applause? Great innovations. Having a good time? Yes? This is good. Very good. I'm pleased to introduce our 5th presenter of the session, Dr. Alyssa Boyd, the Living Wish Foundation, Reframing Hope, One Wish at a Time.
Thank you. So this is my clicker? Yeah. And I just press that? Great. Well, thank you. My name's Alyssa. I'm a palliative care doctor in Collingwood, Ontario, and I'm the co-founder of the Living Wish Foundation. And back in the days when we could do home visits without masks and PPE, there was a young mom I was asked to go see for multiple symptom issues related to her metastatic breast cancer. She was suffering physically and mentally, and before long I realized there was a lot I could offer her. Pain pump, home oxygen, a hospital bed, PSW support, but the one thing she wanted I couldn't give to her. So she was a mom of a 13-year-old girl, and she'd always been the trainer for her soccer team. And being bedbound meant that she would miss the home opener game. And I felt powerless to help her. So how many of you went into this line of work hoping that you would truly be able to make a difference in the quality of life of those who are dying? Yeah, me too. Except most days I spend my time organizing my new consults, doing opioid conversions, trying to figure out how to write orders in our hospital computer system that's new. And I wonder, whose job is it to make sure that these patients are still living, even though they might be dying? So I bet all of you have heard of Make-A-Wish Foundation, right? Did you know that in Canada, before 2019, there was nothing that existed for adults who were in their final life? So that's right, if you were an adult dying in Canada and your wish was to go to Disney World, you'd totally be out of luck. Okay, so I have two pieces of news for you. I'm here proudly presenting our innovation, the Living Wish Foundation, a national charity we founded in 2019 that grants end-of-life wishes to adults in Canada. Our vision is a world where everyone gets to benefit from the joy of one last wish. And we chose the name Living Wish instead of Dying Wish because we want to focus on our goal of reframing hope and bringing a positive energy to a very dark and difficult time. So here's my second piece of news. It turns out that adults don't actually want to go to Disney World when they're dying. So since we've been established, we've granted over 50 wishes, and the range and variability of these wishes continue to amaze, surprise, and inspire us. We've performed weddings, we've held celebrations of life, we've done family photographs, but we've also played a game of euchre with someone in isolation. We got someone a bucket of Chinese food for their final meal, and we outsourced the elusive rum raisin ice cream for one last bite. It has not been easy. We had to get buy-in from our community, we had to navigate charitable status, there's a lot of lawyers' documents involved. We had to find and outsource a used transport vehicle, host fundraising events, make marketing initiatives, get a board, insurance, but the end result is simple. We hope we can bring this initiative nationwide so that every Canadian can benefit. I still think about that mom who never got to go to her daughter's soccer game, but I'm not going to leave you with that because I'm going to show you who did benefit. Robert got to go outside and watch the birds on his front deck. Verna celebrated her 98th birthday with her favorite flavor of cake. Tom had a visit from his dog, Trudy. Mr. K had a visit from his cat, James. Esther had a break from her 300-day hospital admission to attend church with her beloved church community. Doug was housebound for 2 years, and when we gave him a mobility scooter, he got to go visit the neighbors. Howard played harmonica in a backyard concert that he hosted, and Peggy dipped her toes in the waters of Georgian Bay. Trevor and Kathy got married. Baby Lennon wasn't with us for long, but her family have a beautiful photo of their last day together. Trevor went to his first Blue Jays game, and Laura got married at the dock of her cottage. Wes had a virtual visit with his hero, Dan Marino. That's one of our favorites. And Margaret spent the day at the casino with her daughters. Doug had a visit from majestic birds of prey. And these two grandchildren had teddy bears made out of their grandmother's clothing. Oh, I have to go back. Oh, sorry. So these wishes bring so much joy, not just to the patients, but also to their families, their loved ones, their friends, their community, their local hospice, to their frontline healthcare providers. And this is why we are all doing what we do. And seeing these wishes happen and working with members of the team in the community and at events, it's renewed my own personal values and reminds me every day of the goodness that lies in all of our communities and that there's light to be found among even the darkest of roads. Thank you.
Wow, thank you, Dr. Boyd. I want that deal. Anybody else want this deal? Which one of our sharks is going to ask?
I will, if that's okay.
Very good.
Thank you very much for the beautiful presentation, Alyssa. And I too wish that everybody could have their wishes met at the end of life. But I wonder how you are planning to spread this out outside of your community. And I worry, because we know what we're doing here, right? Wish, wonder, worry, about sustainability. You said that it was an awful lot of work to get this rocking and rolling. So what would you recommend?
Well, first of all, I get to talk to Sammy after Better podcast, so that's my first plan. And we just flew to Montreal, so it's the first time we've kind of come out of the province. But we're spreading the news on social media. Our next actual plan as a board is to hire a social media consultant to spread the word. But we've already got wishes extending beyond South Georgian Bay. And every time a wish is granted, one wish percolates to so many people. And then the news spreads, and they post it on social media, and then they tell it to their friends. So we're hoping for the ripple effect as well.
Okay, thank you.
Good. Any other questions?
No, just a comment. I think palliative care is about creating memories, and you are doing just that.
Yes.
Thank you.
Absolutely wonderful. At Mayo Clinic, we always say, think big, start small, go slow. And I think you're seeing acceleration soon. So thank you.
Thank you. Thank you.
Introducing our sixth and final presenter, Kat Brooks from the Roger Nielsen House, presenting The Sibling Experience, Fireside Bereavement Stories.
So it is a true honor to be here today advocating for a group that I am truly passionate about and spent my whole career advocating for, and that is children within palliative care. So in palliative care, COVID-19 hit us hard in our support services with not being able to hold our bereavement groups, our support groups in person. It really let go of a true connection in the support that we were able to have. So instead of letting this linger and stop us from supporting in the way we wanted to, we were inspired to make change and to see past the limits of COVID-19. So we wanted to create a virtual tool that created connection without being in person. We started out with this idea of having a 5-minute video that we would share with the community at large to talk about what death and dying is like for a child. So our goal was to create this vision of a natural environment, literally taking children in nature, where they are grounded and connected to the earth, relaxed to share their most vulnerable experience of their life. So we wanted this to be organic, not an interview with a healthcare professional, a conversation with other kids just like them. And that's what we did. We sat around a campfire and we shared about the death of our sibling. We wanted vulnerability and to advocate for these kids to truly share their story and to provide an opportunity for transformation for them. What was the need? Even before COVID-19, there was a need for this. We need to speak up for kids. Kids have so much to say, and they are often the silent observer in the room when someone is dying, and we are too scared to talk to them. So let's be the people who have difficult conversations with our children. We wanted to create a space of honesty about sharing that difficult things happen and create more awareness for children, for youth, for parents, for caregivers about talking to children about death and dying. So over 7 months, we met together with a group of 10 children in 2 separate groups. Because this wasn't my story to tell. This wasn't my facility's story to tell. This was these children's story to tell. What did they want to tell about their experience? What was it like to live the life of having someone intimately die in their life? So these are all of the ideas that transpired from our conversations. What is it, relationships with friends like after a death? What is it like to interact with your parent? What change happens from a death? What transformation? Over time, how does grief affect you? Which is super interesting because most of these kids were coming back to this experience after a couple years. They had growth, and grief didn't go away. It changed. So what happened? Instead of making a 5-minute video, we made 16 videos of raw footage and modules that we can share with the community at large. These are authentic videos that truly advocate and inspire these children's story of what it is like to lose a brother or a sister or any type of death for a child. And then we celebrated. We rolled out the red carpets, we took over our facility, and we let these kids really know that what they did was inspiring. Because truly, even as an adult, it is hard to talk about something difficult. And these kids were so raw and authentic together. So here is a clip of what we did. Oh.
Everyone kind of needs to think about what they specifically need because it's not going to be the same for any two people.
Do you guys want to share like what might have been something that helped you guys like to like support you in that grieving process, whether it was people or music or an outlet of expression or physical fitness or something?
All of those things, honestly. I mean, I definitely, like they were short term, I'm going to be honest. It was a very rough time at the beginning. Like it was kind of just all of the time it was there. And those things did help with providing me with a little bit of just sort of a clear head for a bit, not really thinking too much, especially with exercise, just kind of not thinking about anything except what I was doing was good. And music was good for remembering, especially, and writing music or listening to music, all of those things.
I was gonna say, after my brother died, it was, one thing I found very challenging was he passed away a few days after he had a serious accident on his four-wheeler. And so one of the things I really enjoyed with my brother was going dirt biking. He would ride his HEV, and we would go together with my dad. And
so all to say that the conversations of these videos is like nothing that you could ever be able to create in an interview, in an interaction as just a healthcare professional. The intimacy, the connection between these children was something more than we could ever explain with words.
Thank you, Kat. Which one of our dragons would like to? Yeah.
Okay, yeah. Well, firstly, thank you. That was very moving and has some personal resonance with me. Kat, how do you think nature changes the way people interact?
Ooh, I love that question. When I first was exploring this topic with children, we were very much talking about a campfire circle, right? And we kept drawing back to the idea of nature because when you're in nature, we can ground to the elements, right? We can connect, we can let go. And it's less intimidating than the four walls of a room and having the lights on us, right? We had distraction of the wind blowing, we roasted marshmallows. And the fact that we were in this intimate space, literally off the beaten trail by ourselves, it was a safe place that they could truly share.
Thank you.
I love a good fire.
Yeah.
And our family used fire a lot during COVID, so I really related and had some difficult discussions around fires. And I see stories as being dynamic and a two-way street. So it's one thing to capture the story as a person who is telling it, but it's another thing for that story to be heard and understood. And I'm wondering, what are you hearing from the young people who were vulnerable enough to create those videos, put them out there from the red carpet? How are they feeling about that now?
Honestly, I think when I first met them, they were terrified and really scared. They didn't know what it was going to be. But as we met for those 7 months, they first didn't want their parents to see it. They didn't want anyone to see it. It wanted to be intimate. By the end, they were literally like, scream it from the rooftops. I want every single person to see this. And it was really just from this desire of being like, I needed this. I need people to know, and I can help people from my story. Very much the transformational grief aspect of it.
Thank you.
Are you going to give us s'mores?
Sure. Do you want some more?
Are there videos that are sort of scaled to different development and
Yeah,
ages?
yeah. So there's 2 groups. The first group was a 10 and 11 year age group, and the other one was, I say he's 13, but he was really in his 20s. They were 18 to 24. And so each of them have 6 to 7 videos of different topics of each one that we as a facility go through in topics that we serve in our bereavement groups, but that anyone in the community at large could use as a support resource.
Great. How about a round of applause for Kat Brooks? Thank you, Kat. Very well done. So in a moment, there will be a slide appearing with instructions on how you can vote. And we'll wait for that. And the judges are going to start their scoring and deliberations. There is the slide. And so you can open your camera's your phone's camera, and then point it to the QR code, and hopefully things will happen just like it says on the screen. And we ask you only to vote once, and you select your favorite innovation. And this will remain open for 90 seconds.
Can we turn the judges' mics off for a sec? Now stop. We are now going to do the iPad draw, and you have to be in the room and present to win. And so I'm going to put my hand in, flip around some cards, and pull one out. And this goes to Valerie Amorosi. Valerie. Not seeing Valerie. I will draw another card. Yeah, it's good?
Okay. So Valerie is the winner of the mini iPod. And round of applause. And the organization will do their best to get that to her, as her contact information is on there. And the judges are still deliberating, and they have just now about 1 minute or so to finish their deliberations. Not to put any pressure on them, and certainly you wouldn't want to be staring their direction. While the judges are busy with their final deliberations, how about another round of applause for all 6? Weren't they great presentations? Yes. I think the true issue here is that these are not sharks and dragons, but these are palliative care people. And frankly, everybody has such a lovely innovation. I mean, really, unbelievable. Absolutely. So. A decision. Am I hearing you guys have made a decision? Yeah. Sounds like we've got a final decision. So at this time, I'd like all the contestants to come to the stage, please. Have you guys reached your decision? Yes? Yes? One moment. Okay, cue right here, please.
It's like American Idol. You have to
go yes.
3 times
And then maybe we collect all the papers. Maybe it would be best if the judges come on up, contestants. And we're going to try and make room for everybody so the audience can see you. Go ahead and filter in, judges around to the side. I would like to announce the second runner-up. Last Wish, Dr. Alyssa Boyd, Living Wish Foundation. Congratulations. Thank you. Yes. I'd like to announce the first runner-up for the 2022 Innovation Challenge, Waiting Room Revolution, Dr. Seow and Sammy Winemaker. Wow, congratulations, congratulations. Which brings me to announcing our 2022 International Innovator of the Year in stiff competition, as you have clearly seen here today. Wonderful innovations across the board. But there can only be one 2022 International Innovator of the Year, and this year that is Bev Foster, room 217. Very good, very good. So, another round of applause for all our innovators. A round of applause and great thank you to Shelley Cory, Canadian Virtual Hospice, for the idea, the inspiration, and innovation for the International Congress. And how about a round of applause for our panel of judges, dragons, and sharks, our review panel, and ultimately the McGill Palliative Care Congress organizers. And we look forward to seeing all of you right back here for the next Innovation Challenge in 2024. Thank you. Wow, congratulations.